at Massachusetts General Hospital with UK and MECFS World. So this is a building called the Lucy Sewell Center, and it's a place where people with opioid addiction can get treatment. It's named after Lucy Sewell, who was one of the first women MDs in the United States. She graduated in 1862 from the New England Hospital for Women and Children. It's on Dimmock Street, and this whole hospital is now called the Dimmock Community Health Center. It's part of the bigger Partners healthcare system that Harvard Med and MGH are part of. So both Susan Dimmock and Lucy Sewell knew this woman, who is Sophia Jex-Blake. She visited the New England Hospital for Women and Children in 1862 and left feeling inspired. She had met Lucy Sewell, who was who had graduated with an MD, and along with Susan Dimmock, Sophia Jex-Blake applied to Harvard Medical School in 1867 and got a letter back saying, quote, "There is no provision for the education of women in any department of this university." So Dimmock went on to apply to medical school in Zurich, but Sophia Jex-Blake had sort of a different plan. She wrote this essay here at the top, "Medicine is a Profession for Women," and then applied in 1869 to the medical faculty of the University of Edinburgh. They rejected her application because they said they wouldn't accommodate a lone female in the faculty. So she then found some friends, the Edinburgh Seven, and got into medical school there. And she wrote to Lucy Sewell, her friend here in Boston, and said, "It is a grand thing to enter the very first British university ever open to women, isn't it?" And they were happy, but they were met with some resistance, and some male medical students, probably with help from professors, held what's called the Surgeons' Hall riots, where they blocked these women from even attending classes. Finally, Sophia Jex-Blake was allowed to take the board exam and awarded her MD in Ireland. And after graduating, wrote this second essay that you see in the middle called "The Medical Education of Women." She dedicated that to Lucy Sewell, and basically called her a noble and pure-minded woman and a thoroughly scientific physician, and was inspired to open up the London School of Medicine for Women, which you may know was later renamed in 1896, later renamed the Royal Free Hospital. And the Royal Free Hospital, of course, is where in 1955 there was an outbreak of encephalomyelitis, this illness that caused sort of long-term consequences in a lot of the women and people that were there. So this was a hospital that was for the poor and for women, and it wasn't well resourced, probably didn't have state-of-the-art facilities, and probably part of the reason that there was an outbreak there. So several papers at the time wrote about this epidemic of neuromyasthenia, said that it seemed kind of like polio. The onset involved symptoms of an upper respiratory infection, unlike the kind I have now, I suppose. Neck stiffness, which is always a sign of meningitis, brain inflammation. Severe headache, sore throat, GI disturbances, vomiting, tinnitus, lymph node, and lassitude, or in other words, medical fatigue. There were essentially three groups of patients: those that recovered, those that sort of had a partial recovery or were sort of in and out, and then those who, excuse me, who were not recovered at all. And this is what caused people to start making a connection. This is from the LANCET in 1956, where the term myalgic encephalomyelitis was coined. And what the authors did was to go through some recent outbreaks of infectious illnesses that looked somewhat like poliovirus for different reasons. Some of the cases they knew, Coxsackie virus, some of the cases they didn't know. At the time, they were trying to investigate cerebrospinal fluid, which, given that we can barely do that well now with current technologies, they didn't have much of a chance. But Bjorn Sigurdsson argued that maybe it was too soon to call it myalgic encephalomyelitis, quote, until we know that inflammatory lesions are in fact present in the brain and spinal cord. And this is still a question that we're trying to answer today, is what's happening in peripheral nerves and in cerebral spinal fluid. So Sigurdsson here was from Iceland and had been monitoring the Akureyri outbreaks there. And this was sort of accepted and known for a while until a psychosocial reframing began. This is in 1970, where Colin McEvedy and Beard wrote a reconsideration of the royal-free epidemic of 1955. And they said that perhaps it seemed more likely that this was a hysterical that this was actually an epidemic of mass hysteria. And one of, they say here, the data which support the hypothesis of mass hysteria are the high attack rate in females compared with males. And so that was sort of just an accepted given that women were more prone to this sort of medical hysteria. And if you look at the first author here, McEvedy, this is a previous paper from this person where they were interested in this potential epidemic of overbreathing among schoolgirls. So you can see this is a person who's very interested in the idea that women are prone to medical hysteria, and this is part of their research program. Another previous research from the same author, an outbreak of winter vomiting disease in a university hall residence, which of course quite likely is, people are sick in the winter, and it happened to be a women's dorm. But this began the reframing of this illness. And to be fair to this author, they did come to the conclusion here that it probably was actually an infectious illness. But in 1985, there was an outbreak of something similar in Incline Village, Nevada in the United States. And people that got sick there often were in buildings that had that were sort of known for having mold in the buildings. And at the same time, there was perhaps some industrial runoff. So it may have been a confluence of these things plus an infectious agent. We still don't really know. So the CDC, the United States CDC came in to investigate. Stephen Strauss, who later apologized, to be fair, referred to this sort of offhandedly as an illness of depressed menopausal women. But the press heard this and sort of took off with it and coined the term yuppie flu. And that really stuck in the United States. And that's how the illness has been framed here. And there was a concern over the Tahoe tourism industry, and as opposed to the term myalgic encephalomyelitis, the term chronic fatigue syndrome was coined, and that sort of has stuck with us here. So that's part of the reason that there's the distinction in terms often used in the United States versus here, versus there in the UK. The way that it was studied, again, sort of follows the same pattern, where here again, Stephen Strauss from the NIH was doing a research study. And here it says, the demography of this syndrome reflects an excessive risk for educated adult white women. This may reflect either a bias towards the cohort of sufferers who can best afford a sophisticated medical evaluation, or some unique constitutional frailty of such individuals. And then he goes on to say that the people who are sick often have histories of unachievable ambitions, poor coping skills, and somatic complaints. So this has been sort of the way that the illness has been framed. In contrast, the term myalgic encephalomyelitis refers to muscle pain related to central nervous system inflammation. And the term neuroinflammation is imprecise. I'll talk about that a little bit in a moment. But one of the best proxies we have is microglia activation. Microglia are the innate immune cells of the central nervous system. And in this paper here from 2014, Nakatomi showed some, in a small study, showed some uptake in the brainstem, especially of patients versus controls. And you can see in the graph that there's a pretty good split between patients and controls. Many different illnesses show some microglia activation, but this shows a pretty good split between patients and controls. So the brainstem, I think, is a really important region to be focused on. And again, if this is an infectious illness, this sort of anatomical based investigation can only tell us so much, but the brainstem is really central to pain processing and neuroinflammation. It's part of the way that the brain finds out that the body is sick, and it's central to autonomic functioning, which is what I'm going to talk about today. These are some nuclei in the brainstem that are particularly important. And if you look through what the brainstem does, it sort of fits with a lot of symptoms that people experience, including, excessive bodily pain, problems with autonomic function, and then neuroinflammation. And you can see here where it says NTS, that's the nucleus of the solitary tract, where the vagus nerve enters and exits the brainstem. And it overlaps really well with this, this is essentially T1 MRI signal in Barndin's paper from 2018. They interpreted as increased myelination. I think there's other interpretations as well, but they found significant difference between patients and controls. And you can see it sort of overlaps with the areas of brainstem that seem to be important for a lot of the symptoms that people with this illness or this diagnosis experience. So the vagus nerve is a mixed cranial nerve. It means it goes towards the brain from the body and towards the body from the brain. That's afferent and efferent. And the afferent function, meaning body to brain, part of what it does is to detect peripheral catecholamines. And what that means is when you have an adrenaline rush, you don't actually have adrenaline flow into your brain easily. It actually doesn't cross the blood-brain barrier, but rather it's detected by the vagus nerve, which then signals the brain. Importantly, it detects local immune signaling molecules. So if you have an infection like I do in my lungs right now, my vagus nerve is detecting locally the immune system. There's a surveillance of the gut microbiome on an ongoing basis, and it triggers the central illness response, which includes a lot of symptoms that people with this diagnosis experience. I wouldn't argue that's the only thing that this illness is, but it seems to be particularly important. And it triggers the microglia activation on the brain side of the blood-brain barrier. And the way that it does that is these immune cells in red detect pathogens and they release cytokines. The cytokines are detected by the vagus nerve, which then sends a nerve signal up into the brainstem. And it can do this because the vagus nerve wanders all over the body and has ganglia all over the body. And the cytokines are then produced de novo on the brain side of the blood-brain barrier, and that's how neuroinflammation is triggered. And so you can see if there's an ongoing detection of inflammation, that could be an ongoing process. The vagus allows detection of local immune signaling. It doesn't have to be infectious, so things like compression can trigger this same dynamic. So these structural issues that people are reporting here and there, part of what may be happening is that there's a glial response to actual pressure, and it triggers the mirror response on the brain side of the blood-brain barrier. So now in the other direction, the vagus nerve has efferent function, meaning brain to body, and it controls the parasympathetic response. It ought to trigger an anti-inflammatory reflex to stop ongoing inflammation. It ought to show parasympathetic autonomic control, which I think is one of the things that a lot of patients with this diagnosis really struggle with, and that includes a tilt table test, which a large number of patients with this diagnosis fail the tilt table test, meaning that they don't properly adjust their posture when they go from lying to standing. And that includes the diagnosis of POTS as part of this autonomic system. We can measure it both with a cardiopulmonary exercise test and with cerebrovascular reactivity, which is the study that I'm describing today. Oh, excuse me, I just forwarded backwards, sorry. So this is Phoebe Chan, our collaborator, working with Ceci, who's a grad student that works with us. And what she's doing is doing a Doppler measurement of the middle cerebral artery. So she's actually directly measuring blood flow into the brain. And Ceci is hooked up with a bunch of peripheral physiology measures, including ECG, pulse oximetry, continuous blood pressure, the actual content of exhaled and inhaled gases, and then breathing, actually measuring her chest as it moves in and out. And what Phoebe has done is to create a regressor where she combines all these peripheral measures into a regressor that predicts blood flow into the brain. And so what we can do is in the scanner, in an fMRI scanner, so it's an MRI scanner that's just used to measure function as well, we can take all these peripheral measurements and do a brain scan where we measure the actual brain blood flow, because oxygenated blood has a slightly different magnetic property than deoxygenated blood. That's why you take iron when you have anemia, because it's, you know, it's measurable with magnets because there's the iron in it. And so this is an example. This is a healthy person just at resting state. And this is not surprising. What you see here is a correlation map where you can see on the right, the red means that there's a high correlation between these peripheral measures of what's happening in the body and the blood flow in the brain. So that makes sense. The amount that you breathe, your heart rate, your blood pressure, and you know, this isn't surprising because we created it this way, right? We created a regressor that predicts blood flow into the brain. When we ask a healthy person to hold their breath, the correlation holds. So the body adjusts properly, and the reason for that is under conditions of hypercapnia, which means high CO2 in the blood, there are changes to peripheral physiology as well as blood flow in the brain. CO2 causes vasodilation, but it ought to cause it in sort of a predictable, known way. And a simple peripheral challenge of holding the breath causes CO2 to increase and causes vasculature to respond. And this is an autonomic function. And we had the hypothesis that maybe this isn't working as well in patients as it is in controls. And it seems to be that that really is the case. So these are patients that are under ICC criteria that have also been seen by a doctor with, you know, 40 years of clinical experience. So we recruit them and we just put them in the scanner and ask them very simply to hold their breath. And you can see at the top at the baseline, first of all, at the baseline for this patient, it doesn't seem to be the case that their peripheral physiology and their brain's vasculature are responding in the same coordinated way that we might expect and hope. But you can see it really drops out when they hold their breath. They really lose the connection between the brain's blood flow and the peripheral physiology. And here's another subject where it's actually better at baseline, and not as bad as the previous subject during the breath hold, but not as good, right? You can see that it moves from sort of red to yellow, and that's just a statistical map. These are statistics that we're seeing, which is a proxy for the biology. So we see a reduce in the correlation during the breath hold. Here's a subject where the correlation really drops off significantly during the breath hold. So when they have increased CO2 in their blood vessels, it doesn't seem to be the case that their brain's vasculature is responding like we would hope. Here's another subject where you can see, again, a decrease in the correlation. And importantly, I think, what we're not seeing is a really specific pattern that just, oh, here it is, here's ME, right? What we're seeing is there's dysfunction in different patients, and the level and degree of the dysfunction is not the same. It's a heterogeneous problem, which I think is part of the reason that this illness has been difficult to study. I do think it's somewhat of a heterogeneous diagnosis and presentation. So here's another example where the correlation between blood measures in the periphery and brain has decreased, and here's another. So these are some examples of patients where we sort of see this problem. And what ought to happen is this vasodilation in the blood vessels of the brain. Blood flows into the brain by a couple different ways, but that includes penetrating arteries that flow in from the meninges. And when penetrating arteries move through the meninges into the brain, they do so through something called Virchow-Robin spaces, or sometimes called perivascular spaces. You can see up at the top of the image is the subarachnoid space. So you can think of that as the meninges towards, which is sort of near the skull. And the blood vessels flow through, and then there's this perivascular space that surrounds the blood vessels. So that ought to be filled with fluid, including cerebral spinal fluid, which is part of how cerebral spinal fluid and this sort of lymph drainage system mixes together and both and moves fluid in and clears fluid out. So when there's problems within the brain tissue itself, a mixture of plasma, cerebral spinal fluid, and interstitial fluid moves out through the perivascular spaces. So it's a way that the brain is cleared. And this is especially important during sleep. Here's just another diagram of the same thing from a different article, showing that these Virchow-Robin spaces are surrounded by astrocytes, which, like microglia, are another immune cell of the central nervous system. Astrocytes, just like microglia, can become activated and can even become infected. So Virchow-Robin spaces, we all have them, but in general, they ought to be pretty small. We see them increasing in size with age and with a lot of neuroinflammatory conditions like autism, Alzheimer's, Parkinson's, etc. And in our hands, we also see them enlarged in many patients with this diagnosis of ME/CFS. So here's some examples. There's some arrows on the left image in the basal ganglia of these Virchow-Robin spaces that are just bigger than they ought to be. And here in the other one, it's in the red nucleus, again, just sort of bigger than they ought to be. Here's a little bit of a close-up that's back in parietal cortex. There's essentially three places where we tend to see these Virchow-Robin spaces, and that's parietal cortex, basal ganglia, and the red nucleus. And here's in the basal ganglia, the type 1. This is a 57-year-old woman who's got a bunch of these enlarged perivascular spaces. Again, I can't look at this and say, there's ME/CFS. But I can look at that and say, you know, for a 57-year-old woman, that's bigger than it ought to be, and there's more of them than there ought to be. And here's a 63-year-old woman, again in the basal ganglia, with enlarged perivascular spaces. Type 2 is in the parietal cortex. This is a 39-year-old male who has a lot of these enlarged perivascular spaces, much more than you should see in a 39-year-old. And again, it's not the case that they're the same for every patient, but it just seems to be that there's more of them and larger than there ought to be. Again, the same male who's sort of got a lot of them. Here's a 57-year-old woman with enlarged perivascular spaces in the parietal cortex. And then type 3 is in the red nucleus in the brainstem midbrain. And here's a 39-year-old male with some enlarged and a 57-year-old female. We obviously chose the best examples so I could illustrate, but we just sort of see these enlarged perivascular spaces as a general pattern. And again, this is, they are part of the penetrating arteries that enters the brain parenchyma from the meninges, and they're surrounded by astrocytes. And interestingly, some papers in other conditions have been looking at these Virchow-Robin spaces because they're probably important. So these are two autopsy studies that I'm showing you here. So this is in autism. Way over on the right is a healthy control, and then the three in pink on the left are autism autopsy cases showing perivascular spaces, and you can just see that they're larger than they should be. And importantly, they found T lymphocytes and cytotoxic astrocytes, including blebs, these sort of strange blisters in autism brains. So Matt Anderson, the final author on this paper, is a pathologist here at Harvard Med, you know, part of what the field of ME/CFS has been trying to do is to set up an autopsy pipeline. You know, with a patient community this large, there's going to be inevitable deaths, and if they want to donate their brains, we want to be able to investigate in an appropriate way. And Matt Anderson has offered, thanks to the efforts of our microbiologist Amy Proal, Matt Anderson has offered to do the exact same study on ME/CFS brains if we have access. And here's an example in Alzheimer's of clonally expanded T cells in the cerebral spinal fluid and around these enlarged perivascular spaces in the Alzheimer's brain. So this shows that these enlarged perivascular spaces in other neurological conditions show activated immune cells, which may be a sign of persistent infection, or at the very least, an ongoing immune response. And so these are some of the things that we're trying to do here, including getting cerebral spinal fluid and looking in the same way. So that's just a taste of what we're doing and what we're planning to do. And I just want to thank a whole bunch of collaborators who work with us. We've got many projects. I only described a tiny little bit here, a lot of different things that we're measuring and studying. And so thanks to my team, and I really appreciate your time.